Um, Great. Well, good afternoon, everyone, and welcome to the meeting after a week break. This is the Tuesday, March 15th edition of the provider update. It's actually been a fairly quiet 2 weeks, so we don't have a lot of updates to share. I think joining us today, Chris Schroeder, of course, and I think Dan is on the call as well as a few people from the immunization program. So let's go ahead and get started. We'll just do a quick overview of where we are, run the numbers as usual. So the big thing really was last Friday was the 2-year anniversary of March 11th, 2020, when the WHO declared COVID-19 a global pandemic. It coincided with the first cases in New Mexico. And I guess I hadn't really thought about this one way or the other, but it was interesting to me that that was the first pandemic since H1N1 in 2009. Not too much new that we added to our timeline. The community transmission across the US is, the map is looking better. I realized as I put this slide together, this map is kind of phasing out. It's a little bit harder to find on the CDC website, and they're really trying to direct people to this one, which is more about community levels. So, but we've been sort of tracking this one, so I continue to include it. The CDC does say, like, if for settings like healthcare centers, this is still a good reference point. But again, they are really pushing people to this map. This map is looking a lot better, especially New Mexico is almost all green. The legend is up here on the right. So we're at low levels, and this has really improved over the last few weeks. And just a reminder that the new map about community levels of COVID is really moving the metric, not completely away from cases, because it still does look at the cases in the past 7 days, but also takes into account the number of new COVID-19 admissions per 100,000 population, and that's a 7-day total, and then the percent of staffed inpatient beds occupied by COVID-19 patients, 7-day average. So still a fair amount of hospital reporting going on, but the idea behind this is really just we do have a lot more community immunity, both people who have tested positive, had COVID, and people who've been vaccinated, and we have more tools for fighting COVID, COVID disease in oral therapeutics and monoclonal antibody. And so one of the things that, efforts should really focus on is protecting hospitals and healthcare systems from being overwhelmed. So on that note, just keeping track of BA2, and this is again the CDC Nowcast, which is predicting, this isn't how it is right now, but does show a prediction of BA2 spread in the US by CDC region. But interestingly, it has been kind of doubling every week. Up here in the northeast of the state, we're looking at about 30% of cases. Now, of course, all the cases are coming down, or at least reported cases are coming down, knowing that there's a lot more home testing around. So it's 23% of, fewer cases. But still, it is interesting to watch. And I'd say the other thing about the US is, it doesn't look like case counts are going up in response to BA2. So if you search on the COVID Act Now website for Maine, Vermont, New Hampshire, some of the states up here in Region 1, they still have that same pattern of cases coming down. However, in Europe, we are hearing about case counts starting to rise, with BA2 being part of that. And again, it gets called the stealth variant because BA2 does not have that S gene target failure, which made it easier for some labs to pick out Omicron. So that is BA2. This is what's happening in New Mexico with regular old Omicron, and just continuing to see a drop in case counts. As people have heard, our infection rate also remains below that critical 0.9. The little upticks intriguing, but probably not completely surprising, given that we have dropped mask mandates across the state. But we'll continue to watch that. Our test positivity is also low, and understanding that metric especially is probably somewhat less reliable, with a lot more home testing that isn't getting reported. Hospitalized patients or hospitalizations have come down. That's great. Vaccines have come down. Sorry, this is so blurry. And that isn't so great. We're down to probably our lowest weekly totals ever, which is about 11,000 the week of 227 to 3.5. The only bit of good news in this, I guess, and this still looks pretty bad, but this is just first doses by day. And I have to say, I was somewhat surprised that, we do continue to have people get a first dose, like start out in this journey. So again, I guess to me, that was sort of good news. Here's our statewide vaccine progress for 5 and over. So everyone who's eligible for a vaccine, and continue to, do well overall in our vaccination rate. So vaccine updates, there's not, we don't have a lot of news from our partners at the CDC. The things we've been tracking of, probably number one is when that Pfizer for 6 months to 4 years old is going to get taken up by the FDA subcommittee, the VRBPAC, and it looks like it may even be delayed to May. And I'll check in with the immunization team just to see, does anyone have any further updates on that?
It's just been kind of mentioned. I don't think there's anything solid, Miranda.
Okay. Then the fourth doses, which again, nothing from the CDC on fourth doses except for the immunocompromised people. But there was a lot of buzz in the news over the weekend and last night, because the Pfizer CEO did say that he thought fourth doses would be important. And I think they have submitted some preliminary data to FDA on this topic. So I think the debate continues about when and if a fourth dose. It also sounds like Pfizer and Moderna are looking at trying to change vaccine formulations so that maybe there's a little bit, so that the vaccines last longer, so we can go to more of a yearly model. But again, that's all kind of news speculation. Dan, did you have anything about any of this?
No, just that Moderna's got that new special booster separate product
Yeah.
that's coming up, but you probably have.
Yes. Do you want to? I think immunization team. So I do not know the most about this. So Dan, please jump in if you want to talk about.
I just saw a quick news article was all.
Yeah. So for the immunization team so we're hearing about Moderna 5, and it's basically a formulation of Moderna that really is a booster only formulation. It's anticipated to be available late March, early April, and will be different than the current Moderna, so not interchangeable. I think its advantage is that smaller packaging and smaller number of doses in the bottle, which will, be a step in the right direction. And so anyway, more on that. I think, I don't know, Andrea, do you have any further updates on that? I think I saw her on the call. And Joelle wasn't able to make it today, but hopefully we will know more about that by the time we meet next time.
Hey, Miranda, this is Edward.
Edward, hi.
Yeah, I got that information from a CDC distribution call that happened on Tuesday. So everything you covered is correct. We don't have anything additional. There will be a CDC meeting tomorrow. I suspect we'll get some more information that we'll be able to share with everyone on this call in a couple of weeks when we come back.
Awesome. Thank you so much. All right. And then the other piece of vaccine news is just the J&J shelf life extension. And, for people overall, we're giving very little J&J. On the other hand, there are some people who are really looking for this vaccine, and there isn't a lot of it around. So kind of important information that for any stock that expires March 7th, 2022 or later, that has an extension. If it's dated prior to March 7th, it needs to get disposed of. And basically, the Janssen website does have an expiration checker. Here's the link here if that helps with any supply. And then, of course, our vaccination team always helpful for sorting these things out. So just to circle back to the fourth dose, and again, nothing specific about, we don't know anything about fourth doses being approved. I think it does sound like, sorry, I'm like stumbling on my words here, that basically there is talk about fourth doses in certain populations. We already have fourth doses in the immune compromised group. But again, we are waiting to hear, like everyone else, what's gonna happen with that. One other thing that I thought was interesting was the MMWR just released kind of a review of a study about the efficacy of vaccine for ages adolescents 5 to 11 and 12 to 15. There was some information about another study that came out that it doesn't look fabulous in terms of the efficacy. This was 1,300 kids in 4 states. It's actually a prospective study where kids get tested every week, which that alone seemed somewhat amazing to me. Started in July 2021. And they did show that there about half of the cases of COVID in this study were asymptomatic, which was I think sort of what we've known, that oftentimes kids are kind of the, carry the disease, but don't get necessarily so sick from it, but are big spreaders. We've seen that with pneumovax. And the more vaccination in kids against pneumovax has really helped decrease the burden of pneumovax in older people. So anyway, this was, in the end, their recommendation was to continue to move along with kids vaccine. This did not talk about hospitalization, some of the worst outcomes. It was just talking about cases. But 31% efficacy in kids ages 5 to 11 and 59% efficacy among persons aged 12 to 15. So it'd be nice if it were a little bit better than that. But this is again just our mega chart of all the immunization recommendations. For immune compromised, again, just remembering that this group really should get 4 doses with a 3-month booster dose interval. I just wanted to share this because I know our texting, the text we sent out did create a certain level of chaos and difficulty for providers, which, that was not good news. But what was interesting here, this is from RTS data, so it's not all the people who are immune compromised or all the people that got vaccine, but it is the people who got texted. And we saw, quite a response to that text. This is the number of people who got vaccine administered that were in that immunocompromised group. And again, not everyone met the criteria and some still got that fourth dose. But I think it is always interesting just thinking about, technology and medicine and what people are responding to. And this was the text. This is just a reminder about the toolkit for immune compromised people. And on therapeutics update, as you know, the Biden administration put out a sort of plan for living with COVID. In it was a test to treat program where pharmacies or it sort of sounded like mostly at pharmacies, people could come in, get tested and treated. So in New Mexico, so one of the issues is that it still requires a prescribing provider to write that prescription. They did not allow pharmacists, the EUA does not allow pharmacists for the oral medications to prescribe. So in New Mexico, that really does not help us a whole lot on this test to treat, pharmacy-based test to treat. When we first heard about it, we were sort of hopeful that, all the pharmacists would be able to participate. So these are the 6 CVS stores in New Mexico that have minute clinics that are participating in test to treat. These sites get their own supply of oral therapeutics. It's not coming out of the state supply. But again, our state supply is actually in pretty good shape. I think really the limitation that I'm sure we all feel is just provider access. Providers are overwhelmed. Finding COVID therapeutics, this is just a reminder that on our website here at cv.nmhealth.org treatments, you can put in which therapeutic you're looking for, which zip code you're in or city, and then it will show which medicine, the medicine and whether it's in stock, where it's in stock. So I just clipped a Farmington zip code and picked any therapeutic so you can see who has Evusheld, Molnupiravir, Sotrovimab, and Paxlovid. The list, went on longer, and our pharmacy team does update this every night with the information they get from pharmacies. I think just a couple other updates. The daily case counts and hospitalizations are now on a new dashboard on the website. And again, sorry for the blurry. It's on that epidemiology reports page. So the EPI team does put together weekly data reports, filled with more specific information. They added to that this sort of daily tiles that show hospitalizations, death cases, and tests. That just started yesterday, and it replaces the a press release that used to go out every day on case reports. And then one other thing I just found interesting, the Kaiser Family Foundation, looked at mental health issues in a survey that they have ongoing, and just, for us to consider other consequences of the COVID-19 pandemic. The baseline in their survey for for mental health issues was 11% of, I should say, anxiety or depression is what they were looking at specifically. And that across the US increased to an average of 31.6%, which is about where New Mexico sits. And that is really all I have today. So let me stop sharing and we'll see if there's any questions. Thanks, everyone.
Hey, Dr. Durham, we had a couple in the chat here from Karen Brown. She says, is there any information for DOH or MATCOM concerning recommendations for reopening outpatient clinics, like decreasing masks, screenings, distancing requirements for staff and or patients? And you are on mute.
Thank you. So I don't know that DOH, okay, so let me say on the mask, on the removing the mask mandate, the DOH did still say in hospital settings, masks should be worn in a few other congregate setting situations. For outpatient medicine, it really is up to, the individual organization. What we've done here in our clinical settings at DOH and kind of really all the offices associated with them is try to open up more, but maintain masking. Because again, the lower case counts just make it feel like COVID is over, but there still are. And I think what is sort of important to remember is just that we see these lower case counts, but there are an awful lot of cases that aren't getting reported because they're being done as home tests, which is okay, but just to remember that we're not seeing the full picture the way we used to.
Yeah, well, we are, thanks for that. We're just feeling a lot of pressure from people, our own staff and patients, and so we're just like trying to figure out ways to open gradually decrease. And it's hard because, hard to find data, hard to find recommendations. So we were just wondering if there was any guidance, or whether we just try to do sort of a stepwise cautious approach and see if our staff numbers go soaring or whatever.
Yeah, the guidance from really being in the public health order really just focused on hospital settings. So you can kind of tag along with that, which is sort of what we did, but we also just felt like I think, as you're saying, it was worth it to be cautious and not have a big rebounding cases, much as we'd all love to let go of our masks, but and then kind of remembering that I think we talked a lot about really all along what we have seen is there's some work exposure, but actually most of our staff, really the ones got exposed elsewhere. And so what's happening now is everyone does go out and shop and not wear their mask because they don't have to, but then they come to work. So that's also sort of prompted us to say, we'll be kind of the holdout setting for masking. And I don't know, Dan, you might have.
Yeah, I think it's tough because it's not black and white right now. So, and we're all just hoping, but there could be another surge. But in the meantime, I think what we're doing is keeping our masks on in the public health office setting. But we can't really, without a mask mandate, we can't insist that our clients do the same thing, or our patients. So, we can recommend it and request it, but we certainly aren't able to, to say you can't come in if you're not wearing a mask. So we've sort of, I think we're in that kind of middle ground. So it's
thanks for the discussion. We're still kind of following OSHA until it gets because the New Mexico guidance says to follow the CDC, and the CDC still says masking too, and in healthcare settings. So we're definitely doing that. So thanks for your perspectives.
Thank you.
Andrea Romero, I believe this was in regards to the question above. No mention from the CDC. Victoria, I have a question regarding AstraZeneca. If an individual received both doses, are they able to receive a Pfizer or Moderna booster?
Yes, they are. So basically, once the difference here, so it used to be just Pfizer, now it can be Pfizer or Moderna. The difference is, both those were allowable once the vaccine got fully approved by the FDA. Once it gets fully approved by the FDA, CDC gets to make extra rules about it without it going through that whole EUA process. And those are under the emergency use instructions. So basically now with AstraZeneca or any of the other WHO approved, but non-FDA approved, you can just kind of pick up wherever the person left off with Pfizer or Moderna. So if someone got one dose of AstraZeneca, in 4 weeks, they can get either Moderna or Pfizer and then keep marching along. If they've had 2 doses, they can pick up with the booster. If they need that additional dose, they can do that. So it's made it a lot easier, I think. And that's been super confusing. It has gone back and forth and all around, but I think don't really anticipate a change now. I don't know why I said that. There's always going to be a change, but
Okay, awesome. Thank you. Victoria says thank you as well. So Karen Brown says, is there any data about COVID-19 transmission? And if you have a primary series versus primary series plus booster?
yes. Well, actually, are you specifically talking about transmission or about getting COVID?
Yeah, so we're talking about kind of transmission, because as same part of this question where we require a primary series for employment for our staff. But we're thinking, could we open the break room and let people sit in there and eat without, without masks on in an area where there wouldn't be patients? But yeah, we know that vaccinated folks got COVID quite a bit. And that they were more protected from hospitalization and death with the booster. So we're just trying to weigh that in and see if we need to start making sure people have boosters or if there's data about that.
So on the DOH side, we definitely have a fair amount of data on breakthrough cases. And again, the number of people with breakthrough cases was much less if they had had a booster. And there's also an interesting graph showing kind of time from booster and the number of breakthrough cases in boosted people that I can send you and try to remember to put in here. But I think, there was so much debate about boosters at the beginning, and I think boosters were getting talked about before we even knew about Omicron. But I think as Omicron came, there's no question that even the booster skeptics moved towards recognizing that the third dose, the booster dose, was super helpful in preventing cases. Presumably transmission, because they weren't getting COVID. But it wasn't 100%, and definitely time from booster started to see an uptick of cases. And I think that's kind of the debate about this 4th dose and even when to get it. Like if you get your 4th dose now and we don't see a new, BA2 doesn't come around for another 4 months, like, is that booster going to be useful? And again, there's sort of a difference between the usefulness in preventing cases and the usefulness in preventing bad outcomes. But in a work setting, you're really interested in preventing cases. I mean, of course, the bad outcomes too, but so I can send you that one slide. But Dan, can you think of anything else that, or anyone?
There was an interesting, I think, New York Times article sort of comparing red states and blue states and talking about how, the masking, much greater masking in blue states than red states didn't seem to really, make a big difference in transmissibility. So that maybe goes to your question of the break room. But that the big difference was the vaccines, and the biggest difference was on deaths and hospitalizations, not so much transmissibility. I think there's some advantage on transmissibility with vaccines, but the big protection is really against the bad outcomes. So I think that's the bottom line. It's still tough to make choices on what to do in the break room, but I'd let them eat. That's what I would do. Just personal opinion.
Great, thanks for that.
Okay, and then Kenneth asks, is a prescription from a physician required to dispense oral COVID therapeutics, molnupiravir?
Yes, so molnupiravir and Paxlovid really all of them, the Evusheld, the sotrovimab, they're all a provider prescription is required.
And they're really being underprescribed. So if people have use for them, or even possible use for them, don't hold back, because there's plenty of supply relative to demand.
Great point. Yes. And we still do have, so the oral therapeutics have expanded to many more pharmacies. It was just at Walgreens at the beginning. It also has a lot of the FQHCs. So there was a separate FQHC program that I don't think was maybe super effective at getting medications to the FQHCs. But then our pharmacy program has also made sure that FQHCs, if they want it, working with them to be able to prescribe it. So those are kind of test to treat sites also. They're just not in that sort of formal test to treat program, which is providing this extra supply of vaccine, the CVS program effectively in New Mexico, those 6 sites. But definitely those 6 sites, I mean, a good resource for patients. And then again, we do still have the mail order Walgreens. So if you are somewhere that doesn't have great access to pharmacies or providers with the oral therapeutics, keep that in mind. I know the turnaround time is a little tough, but they'll overnight it to your patient.
And this just in from email from Toby Kessler from Aging and Long-Term Services. Hi, Toby. Thank you. He said he's sending an article that Pfizer is going to seek the second coronavirus booster shot for people 65 and older, and that the submission is expected as soon as Tuesday. I assume this Tuesday. So anyway, that's happening. But interestingly enough, just for 65 and over, which makes a lot of sense, because the risk of bad outcomes goes up so astronomically in the higher years. So there you go.
Awesome.
Okay, great. That's the end of the questions in the chat. If there's anything else, if somebody wants to throw a question in the chat and or just jump on and ask your question. Otherwise, we can reclaim 23 minutes of our life. Going once, going twice. Okay, Dr. Durham, Dan, if you guys want to close this out, you're more than welcome to.
Awesome. I just want to say thank you so much for joining us. And we have set this at an every other week cadence now, unless something comes up in the meantime. But really appreciate everyone joining and all that you do.
Thank you guys so much. Appreciate it.